Good morning, everybody. As you're signing on, you might notice that we are asking, if you can, to fill out a survey for the LA County Department of Public Health related to comprehensive medication management. If you have a phone, you can scan the QR code and you'll have another chance to pull this up at the end of this presentation. Wait a little bit longer. I think we have a few more participants that are signing on right now. The survey, by the way, has also been dropped in your chat. Thanks. Give it just another minute or two at the most. Okay, again, for those of you that are coming on right now, we dropped a link in the chat to a survey that we need everyone to complete from the LA County Department of Public Health. Looks like we're still trickling up in numbers. And in just a minute, I'm going to get started. Okay, good morning, and thank you all for joining us on this Sunday. If you wouldn't mind, for those of you that can and didn't just wake up and get out of bed, if you could put on your cameras, we'd love to see your faces, but it's an option. I understand how Sunday mornings can be. All right, welcome to our keynote for the spring 2022 learning session, and not quite there yet. This is our annual event where we bring our teams together. Our teams being the California RightMeds Collaborative Pharmacy teams to advance their training and skills and get some insights, key insights as to where healthcare is headed and how they can best align the work they're doing with what's coming up very soon and near and mid-range future. And today is going to be a powerhouse keynote. I mean, I'm so excited about what you're going to hear today. Quick housekeeping, people you need to know, we have just welcomed Lisa McDonald as our Associate Director of Continuing Professional Development. She's waiting right now. If you have any questions that relate to CE, please connect with her. Shaden Das, I think, is also on here. She's the person who manages technical issues. Feel free to connect with her if you have any. And I didn't finish my instructions that I was going to type out here, but please adjust your view to optimize your attendance and participation in this conference. So, you have all different ways you can just Zoom to optimize looking at the people and looking at the presentation. For example, on the monitor, I have the presentation. On the other, I have as many names as possible showing for participants. So just do whatever it takes to get you most engaged in the program. CE instructions, you're going to get them at the end. Lisa's going to recap them for us when we're all done. And again, the survey link, which you saw at the beginning, which is now in the chat, you could please complete that. Ideally by the 22nd, which is the learning session in Las Vegas with CPHA's Western Pharmacy Exchange, would be fantastic. Really appreciate that. Okay, so we're going to pop just a couple of really quick polling questions for you, just to get us kicked off. Here are the two. You can scroll down for the second one. Let's take about a minute to answer these. First is rate your level of experience with comprehensive medication management. Okay. And the second is, what are the greatest barriers you face in expanding comprehensive medication management practice opportunities? And you can select all that apply.
Thanks, Mom.
Right.
All right, we're getting there. About a little more than half of you have responded so far. Another maybe 10 seconds. I think we're gonna get everybody. Okay. All right, just a reminder, if you're not speaking, would you mind muting? I know that it's hard to remember all those things, even I do that on occasion. Okay, why don't we stop? Do you want to end the poll, Lisa, and share the results? Okay. Let's see, I'm sorry, did I just close the results? Can you see the results, anybody? I'm not seeing them on my screen. Lisa, can you see them?
You can see them on my screen.
Yes.
Oh, okay. For some reason, I might. So can Lisa, can you go over the results, please? For some reason, they're not on the screen.
Can you see them now?
Oh, I can now. Thank you. Okay. So we have a mix of people with CMM experience. I'd say a little more than half, maybe 60% have some CMM experience, a third with 3 or more. The other roughly 40% have no CMM practice experience, most being familiar. And then when talking about what are the barriers, payment comes near the top, working with physicians, pretty close to the top, time available, need more training, access to patient records. This is great. So for those of you that are in our collaborative, you know that these barriers are very much what we focus on to try to facilitate your availability to provide CMM, be sufficiently paid, and as a result, have the resources necessary to be able to provide it. So this is super helpful. Thank you so much. Okay, I'm trying to close that out. Okay, now in the chat, last thing I'm going to ask you to do, when complete the sentence. When I think of comprehensive medication management, I feel blank. It could be a word, it could be a sentence, it could be an emotion, it could be something concrete, whatever comes to mind. I want to be creative. When I think of comprehensive medication management, I feel excited, confused, something. So just drop that in the chat for us, please. Let's get as many responses as you can get here. Someone stole my excited one. All right. We got hopeful, we have empowered to make a difference. We hear that from a lot of our teams, saying that this is the first opportunity they've had to do some very extended with their patients. Hopeful, wishful. I hopefully we're beyond wishful, but I like that word. It's great. Passionate, Lily. Thank you. Great. Ram, a way forward to better manage health. Yes. Okay. Fantastic. Thank you. Okay, so this tells me that this is the right audience, right? This is a group that's optimistic, that's looking forward and believes that there's not just opportunity, but need. That's exactly what we're here today. And to further explain why we're here, kind of the simple bottom line, we're here to advance comprehensive medication management as a proven framework for optimizing medication therapy. And what defines the California Right Meds Collaborative is we're doing this in a way where we're not asking for fee for service. We're not saying that that's the only way it works, because it doesn't guarantee the outcomes that payers are seeking. So everything we do within Cal Right Meds is through a value-based payment. And for those of you teams that are within, you understand what that means. For those of you that don't, we will cover more of that in the actual learning session coming up on the 22nd. So just to kind of recap where we're at today, this has been a tough 3 years. I know you all know this. You know, before the pandemic, there was very much wellness focused, staying away from negative people, right? That was sort of the theme. Then comes the pandemic, and now you stay away from positive people, right? As in positive COVID. 2021, boy, things are really taking off with COVID. We thought we could predict what was going to happen. We were wrong. It became stay away from everybody. And in 2022, now we're asked to sort of be patient, right? And be positive. And it's pretty confusing, right? The whole thing is. And I think the bottom line is the experts can't get it right necessarily. And that's just the nature of this pandemic, right? It's just when we think we have it cornered, it takes another turn. But one thing that has been consistent is this graphic that came in 2020 that said 4 waves of COVID. that are really going to slam us, right? We've been through the first, the second, we're now really hitting hard on that third and fourth wave, right? All these patients that neglected care during the pandemic, that interrupted care for chronic conditions is now slamming us in our healthcare system. Patients with cardiovascular conditions, with neurologic conditions, with cancers that just didn't go in to get care. We're seeing them now, and things are not good, right? We're trying to catch up. And keep in mind, before the pandemic, we were not doing well already with these chronic conditions. We were one of the worst in the world in developed countries in quality of care. Now things have gotten worse. And it's that fourth wave that we really are stressing out about now, right? It's all the psychological trauma that COVID has caused, the mental illness that we had a problem with before is much more difficult now than it has been. The burnout among healthcare workers, we're seeing it in every sector, right, including pharmacy, economic injury. And then I added the health disparities piece because that was highlighted, unfortunately, dramatically by the pandemic, in that we saw underserved populations consistently being under-vaccinated in our communities. And that translates into outcomes in chronic diseases that are further going to be more disparate if we don't do something about it. So these are very dire things that have happened over this time period. And in all the conversations I've had with many of the, including with the experts we're going to hear from today, we're hearing over and over again that healthcare needs to dramatically improve health outcomes. And we know that that's not achievable without optimization of drug therapy, right? And these are some of the things that I've shared with many of you already before, but the cost, the mortality consequences, the hospital readmissions, all of these things are driven by medication therapy optimization. We can do better. We have to do better. And it's really a shame, if you really think about this, that we have so many pharmacies out in the community that have not been fully integrated with the health system. I mean, there are obviously great services that are provided there. The pandemic showed that public health can't survive without pharmacies in the community. But what about all the other pieces we're talking about here? Managing chronic conditions, getting patients screened for conditions, getting them connected to managing social determinants. That could be done so much more coordinated and efficiency in partnership with community pharmacies. And this is very much the vision, right, of where we're headed with the California Right Meds Collaborative. Our program is basically a sustainable and scalable value-based medication optimization service that partners plans with physicians and medical and pharmacists, which we know are trusted, widely available, highly accessible. We coach you guys to death, for those of you know in the collaborative. We monitor your work. We do very aggressive CQI. And your pharmacies are often culturally and linguistically aligned with the population served. Such an ideal community-based hub for extending the healthcare system that we're really excited about pursuing and pushing through our collaborative. So, with that in mind, with this year's learning session, we wanted to focus on some of the key struggles that patients are having, which I'll get to a little bit later. But we also wanted to bring to the forefront some of the critical thinking and the support we have, I would say, outside the profession of pharmacy that really is making all the difference. So in a minute, I'll introduce our two speakers, but the content of what you're about to hear covers this theme of the Cal Right Meds Collaborative as a strategy and investment for health improvement and equity. There are three basic components of what you're going to hear today. The first is how comprehensive medication management is an investment in all three buckets of prevention, providing community clinic linkages, leading to community health improvement. You're going to hear about public health 3.0 opportunities that utilize a whole government approach. And then the care model, the importance of community engagement and empowerment, and the collective wellness as aspects of CMM to reduce health disparities and promote health equity. After we're done with this keynote, we're going to collect just a little bit of information for you to prepare for the April 22nd live learning session, and then we'll send you off for the rest of your day. So in trying to introduce our speakers, and I'm not trying to make light of this terrible tragedy we have happening across the world in Ukraine, but in trying to think about we have here today, I want to be very clear that the two key speakers that we have are powerhouse leaders, really and I'm no exaggeration, powerhouse leaders. But then I thought about it a little bit, and I thought, they're also bosses, not this kind of boss. They're also bosses. They're the kind of boss that my favorite organizational psychologist Adam Grant describes. They're the kind of bosses that develop your career and ask you how you want to make a difference. I've seen this over and over again with our two speakers, and I'm just so thrilled that they're taking this time this Sunday to share their expertise and what they've done for healthcare as a whole, and really for the profession of pharmacy in many ways. I'm going to introduce Dr. Jessica Nunes-Debar first, and then Liz up and introduce her separately. But just the formal part of Dr. Nunes-Debar's bio is she's a board certified in public health and general medicine and a fellow of the American College of Medicine. She currently serves, I had to update her title because I had it wrong just a little while ago, currently serves as the Community Health Medical Administrator, leading a special project in the California Department of Public Health Director's Office to plan, develop, and align the department's specific goals and strategies for community health investments and improvement efforts. And this includes identifying and adopting financing models that pay for prevention strategies focused on the most vulnerable populations in California. So perfectly aligned with this work that we're doing. I should also add that she founded the CMM statewide work group that I've been a part of for I think 6 years or maybe going on 7, that has consistently been supportive of advancing CMM practice for pharmacists across the state. She was previously the chief of the chronic disease control branch for the California Department of Public Health. In 2014, she authored and led the authorship of the California Wellness Plan. This was an exhaustive plan the state had in chronic disease prevention and health promotion. And a big part of that was a focus on comprehensive medication management, which is how we started to get connected and work together. She previously worked in the CDPH's Division of Communicable Disease Control, facilitating internal public health communications, training, and preparedness, activities addressing emerging infectious public health threats. So she was well prepared for the pandemic. And I saw the moment that her understanding of what was present and to come was far ahead of everyone else I had worked with. She's a volunteer faculty member at UC Davis School of Medicine, serves as president of the Sacramento Latino Medical Association. And I, just on a personal level, I have been in awe and humbled working with this amazing leader for going on close to 6-7+ years now. Her knowledge of what's happening in healthcare and her ability to take that knowledge and translate it into real results is like nothing I've ever seen. I've never seen anyone so passionate about dramatically improving health for not just all Californians, but those that are most challenged to get good care. I'm always thrilled to be in any meeting or effort where Dr. Jessica Nunes-Debar is involved. And she's going to share a lot of information today that should get you really excited and get you thinking about how pharmacy can step up. I might want to describe the role actually of both Jessica and Liz as almost throwing a softball at the profession of pharmacy, giving us great opportunities to contribute to major needs and gaps in healthcare. And sometimes I wonder, do they look at pharmacists and say, why are you not hitting this out of the park? You know, we're setting you up to be successful here. So hopefully you're going to see all this amazing work that they do to help us help patients get better care. So with that, I'm going to introduce first Dr. Jessica Nunes-Debar.
Thank you so much. I'm so privileged and could say quite a few similar basic, I don't know, I'm just blown away right now. Thank you, Stephen. Liz and Stephen have been just an amazing team. As inspired I am by what was just stated, I'm also inspired about each and every one of you being here on a Sunday. So let me just frame this presentation before I begin. You will have access to the slide presentation after the meeting. Lisa McDonald is going to assure that. What I want to share with you is it is a really great resource. And so I'm going to go pretty quickly through this and we'll have Q&A after. But I feel since January of this year, which is this is my 3rd month in the role in the director's office at the California Department of Public Health, to really look at these issues. So I'm sharing with you some of what I've learned, some highlights that I think are really unprecedented, a huge investment. So let's get started. Next slide. I have no conflicts of interest to report, and these views that I'm going to share with you are my own. Next. Again, you've seen the exciting objectives for the day. Next. But what I want to start with is to share with you, yes, I formally work for the state of California in the Department of Public Health, but public health in its pure understanding, or at least my understanding, is what we as a society, meaning I can't do anything good in public health without each and every one of you. It's what we collectively do to ensure that our communities that we live in are able to have opportunities for health. So this is very exciting to me that we're here together and that I get to, I feel really honored to speak to this. So let's proceed. Let's dig in. Okay. So the first thing I want you to appreciate, and we're going to be doing this over and over again in this talk today, which is make clear, how do we do public health? Well, there are three core functions of public health: assessment. What is the problem? Policy development and assurance. So for instance, let's take COVID. We assessed there was a new threat, a pandemic. We created opportunities for assuring that we could address that threat. Vaccinations, for instance, your role in those vaccinations. Assurance is making sure and looking at the rates. Did we do well? How's it going? Continuing to monitor to make sure the threat is beyond us or behind us. So these are themes that are going to be relayed to you in the way I think about the frame of moving forward together, because there's a lot of information that has been thrown at all of us in recent days, months, years. You saw the trends that Stephen shared, and this is one way I try to kind of keep it simple. Okay, next slide. Health equity. Why do we care about health equity? Stephen shared in that slide all the disparate impacts of COVID and other pressures that are bubbling up right now. And, you know, it really is just this previous definition really I like so much. You know, let's get and ensure the highest level of health for everyone, right? An equal opportunity, and you can see the definition there. Next slide. So yes, threats to public health, and even at the health department, we have 200 programs at the state to address so many levels of threat. Things that injure, maim, kill people are what we think about, and we try to mitigate and prevent that every day. Next slide. You have seen as a group how trusted you are. The President of the United States, you can go to this fact sheet, is looking at pharmacy-based clinics to be in a role moving forward as part of our response, thinking about testing and treatment. And you've seen some really great sort of ideas about what pharmacy can do. Next slide. However, when we look at where we've been, it's very concerning. And again, this is the assessment part of my job. Recently, and I don't know if any of you looked at this, and if you later on, when you go to the that title, 2020 increases in deaths in California, it'll take you to the brief that's on our website. The key to appreciate is that we had excessive mortality in California. What does that mean? What it means is that there were more deaths than we anticipated in 2020. Yes, 15.9% of an increase of deaths than we would have expected. Yes, it was partially due to COVID, but other causes also. And there were extreme distinctions in who died. And you can read there how it impacted folks, but striking increases among Latinos. If you look at that last bullet, among Latinos, there was a 64.9% increase in the fourth quarter of 2020. And what we found is that 2021, which is just closed in our minds, and we'll have that data too, it was just going through the roof, which is very upsetting. They say that Latinos lost 3.5 years of life expectancy in this. I mean, it's not an unsubstantial change. Okay, next slide. The other problems, and you're probably well aware of this also, drug overdose, homicide, Alzheimer's, ischemic heart disease. The concern I had was, wow, we had been making some inroads on ischemic heart disease and even homicide. So these increases were very sad to us. And then age had a lot to do with it as well. And you can read those details there. Next slide. So then again, we think of, gosh, all these challenges we need to have in an environment where things are just getting so much harder, the value of CMM. So next slide. This is something that you'll be tested on, so focus on this. The care model. Why do we care about the care model? Why do we have to start with people first? Why do we care what a community thinks about? Well, this very group is about talking to pharmacists, is to hear what you have to say. It's a concerted effort to start with you first. And that really is required in any effort, anything we're going to do to intervene. We have to think about meaningful community engagement, realizing people have been traumatized, and you don't want to add to the harm to any group. So think about these 4 principles in any intervention. Community, being involved from the beginning, not as an afterthought, not something that you do upon a group, but in combination with them. And to some degree, at the bottom of this slide, you'll see that there's a link to this huge workshop that happened recently that said we need to do more to empower community to take control of the situation and really direct things. That's the goal. That being said, A is for advocacy, right? How can they, within their own community, think about these disparities and think about how to ameliorate or to do more with the resources that they have to prevent or mitigate these impacts. Then to also think about resilience. And there are a lot of really great areas of resilience description. And the reason I talk about resilience, because some people think of it as kind of theoretical, academic, not really important, but think about it this way. When you try to help someone, you can do your best to reduce risk, like an immunization. But resilience says, do you have the energy, the capacity, the heart, the wherewithal to move forward? And I've heard recently from a colleague that she thinks about it most in children. What are we doing to make resilient kids? And the Surgeon General for California created a great report. She has some great models that you can look at also. But the key is resilience means that you're filling their backpack with treats and positive incentives and ways to keep going and thinking about the proactive approach, really giving them time to have the energy to move forward beyond just risk reduction. So it's a really important concept. And then finally, let's get the data, kind of like some of the data I showed you at the beginning of this PowerPoint, for helping to inform our decision making. Okay, next slide. All right, so again, lots of very complicated models about all the ways that the environment impacts us and over the life course, and just really sophisticated ways of thinking. And the work's been done. So I'll leave that here. You all have a sense of that because every day you're dealing with many of the circles, the nested circles that illustrate this complex socio-cultural environment that shapes one's development and opportunities for intervention. Next slide. We even have sort of a thought that much of the upstream prevention can help many problems, right? This is a really very sophisticated model of prevention that I want to walk you through because there is at the bottom those 2 gray bubbles that show potentially modifiable areas that we can intervene 40% of the time, 60% of the time, no. But for dementia, that's powerful. And if you look at the beginning of your life, education is a powerful protector against dementia. Then you go to midlife, and hearing loss, traumatic brain injury, hypertension, alcohol, obesity come into play. At the end of life or later life, at my age, you have to think about smoking, depression, social isolation, physical inactivity, air pollution, diabetes. A lot of these areas, you say to yourself, wow, you know, we're working in this space as pharmacists with CMM. This is like our bread and butter. Well, guess what? You're also helping to prevent dementia. And I share that with you because this is powerful. This has been researched. This is known. So what are we going to do about this? Okay, next slide. Well, to some degree, we want to make it a little simpler. So next slide. This is important for you to understand also for your test coming up. Traditional clinical prevention on the left, innovative clinical prevention in the middle, and total population or community-wide prevention on the right. The reason I'm sharing this is because what you see, next slide. Now I've added this, but what you see is the role of the pharmacist in CMM bridges all those buckets. Okay, I'm going to go into the details, but what you'll see is the healthcare has typically been in the clinical piece and space where you just very safe with those evidence-based services. In the middle, they think about the community clinical linkage. And then public health has been alone often in these campaigns to reach the whole population, policy. And the thought is, you are that link to some degree, often on your own. You know, for every pharmacist, there are 4 doctors in California. For every pharmacist, there's even 12 nurses. You are a special group of people that are being asked to do more and more in every space every day. So kudos to you. Let's look at these 3 buckets just so that you have a frame when you're talking to people, because sometimes I think this is easier for people to understand than that broader concept. Next slide. So traditional, again, is like the vaccines you give, screening for obesity, screening for tobacco use, all the things that you can do and have done, and that there's, you know, historic reimbursement. And much of it was changed by the Affordable Care Act to have no cost sharing. But there is room for improvement. Even in these traditional buckets, we aren't going as far as we could go. And, you know, the beauty is years ago, CDC, the Centers for Disease Control and Prevention at the national level, had this 618 initiative. If you go and look at that, you can see they have made clear: reduce tobacco use, control blood pressure, improve antibiotic use, which means be careful, don't overprescribe, right? Control asthma, prevent unintended pregnancy, prevent type 2 diabetes. All the areas of focus are all in your lane. You probably say to yourself, oh my gosh, that's stuff there's a medication for each of these areas. I have a rule. And guess what? If we could work on those alone, because these are high burden conditions with known interventions like CMM, my goodness, the good we could do together. Okay, so that's just in the traditional space. Next slide. But then, you know, you think about the place we've gone with COVID. We're in the homes now, telehealth. National Diabetes Prevention Program, all these team-based care approaches. Even the community guide, the guide to community preventive services, there's a link there, shows that team-based care increases the proportion of patients with controlled blood pressure and reduces, you know, the impacts. And that it's the pharmacist that helps with much of this. It's very exciting to see all those that have accolades for your role. Next slide. That final bucket includes, wow, you know, who do we want to target on a global basis? And policy often includes like a tobacco tax, access to healthy foods, opportunities for physical activity, safe and clean housing. You know, the health department often does big media campaigns to get people to think about a resource and make themselves avail that resources. And you guys often, in terms of COVID, had the resources within your purview. So again, the beauty was even in the community guide, they found that when pharmacists were involved, you made the difference in heart disease and stroke prevention. And I'm sharing that with you because it spells it out that you all can make a huge impact. And again, heart disease went up, remember? You have a valuable role. And when you make your case, you need to really tell people are dying of heart disease more than they ever have. You have the data and you have the intervention as evidence. It's there. And so it's just outstanding that all this is in play for you to make the best of an impact and of a strategy. Next slide. Okay, so what they've also found is when all three buckets are activated, we have the most impact. And you can see an example there from Massachusetts where, you know, there was tobacco cessation medications at no cost for Medicaid, and we have that in California. And then patients were linked to counselors on a quit line, which we have in California. And then the state promoted the benefits of tobacco cessation interventions, which we have in California. So we have these models in play in California. And the key is, what other ways can we exert all three buckets? Now, I'm not here to tell you what those are, but these are frames that I want you to think carefully about when you move forward. You need to think about, do we have all three buckets engaged, full and ready to go? Next slide. All right, so the other exciting news is my new role as the Community Health Medical Administrator in the Director's Office at the state. You know, we are willing now to think about as a whole of government approach to think about community health improvement. We have to identify, remember, the three functions of public health, and we need to identify the needs of the community and address the needs. And we just laid out strategies that will work. So this to me is core. We can do better if we come together to this. And again, when you look at the 4 action areas that they say that you need to leverage, you think about socioeconomic factors, physical environment, health behaviors, and clinical care. And you can see more at the CDC Community Health Improvement Navigator. They have resources there and ways to think about this. So there are a lot of resources in this space that I wanted to share with you. Next slide. So the other piece, and this is the final quiz question for you, is Public Health 3.0. And again, you see that that title is underlined. So there's a link there to the article and the push by CDC, the Centers for Disease Control Prevention at the national level. They made clear that we need to think about governmental public health, but in some respects, it speaks to all of us, right? How are we doing in leadership and workforce? How are we making these partnerships real? How are we looking at infrastructure and accreditation? How are we thinking about timely and local relevant data, metrics, and analysis? How do we think about funding? And what I want to share with you is a letter from our agency secretary, Mark Galley, who's a physician, pediatrician who cares about kids. But if you go to that link at the bottom, you'll see his hope and all the investments made that I'm going to be discussing with you now. Next slide. The other thing I want to share with you is there is a Future of Public Health work group that came together and put out a memo in September of 2021. These are similar types of areas of focus for the Department of Public Health as they've proposed. There may be funds coming to the department, but what you'll see is the 6th one is community health improvement. This is an area I'm very interested in my new role. Whether that funding comes or not, the request has been made of me to think about where we can leverage some of these areas. If you go to the bottom, you can actually read that memo that was presented to the legislature and is available on our website. Next slide. So the beauty here is this is where the presentation is going to go fast and is overwhelming. I hope all of you have heard about CalAIM. California has an advancing and innovating Medi-Cal initiative, and there are so many. This is the laundry list of them right here. It's called CalAIM for short. It's being led by the California Department of Healthcare Services, and it has many attributes that kind of blend into other areas. But I'm going to focus on 3 for purposes of getting through this presentation quickly. The first one is aligned delivery systems, and at the bottom you can see more of these details. Next slide. This is important because they were approved, the California Department of Healthcare Services, to have these 4 programs creating or moved into one, merged into one. A single waiver oversees all 4 of these areas. Next slide. Enhanced care management. I'm sure you've all heard of this. This is also an approved CalAIM initiative. Next slide. Now, this is interesting because it really has attributes that you're all familiar with as practitioners of CMM, comprehensive medication management. It has a whole person interdisciplinary approach to care. It looks at clinical and non-clinical needs of the beneficiary. And again, this is Medicaid beneficiaries, which are, again, beneficiaries currently are 1/3 of the state. So this is not a small group of people. It requires systematic coordination of services and comprehensive care management across physical and behavioral health delivery. And they're looking for community-based, interdisciplinary, high-touch and person-centered for the most, those most in need. So this isn't, ECM isn't for everyone. Okay, so let me tell you more about it. Next slide. These are the services that can be provided to a patient. Next slide. And this is the transition time. Okay. All members served previously, and it was only certain jurisdictions, by Health Homes Program or Whole Person Care are going to be transitioned to this ECM and in lieu of services, which I'll tell you about in a minute. ECM begins for the following populations in these counties in January. So this has already happened. Health Homes Program and Whole Person Care doesn't exist anymore. It's over. It expired. Those folks are all dumped into or transitioned into this new ECM, but only for the following populations: homeless individuals, children and adults, adults with high utilization, and adults with severe mental illness and substance use disorder. All managed care plans for Medicaid may begin offering pre-approved in lieu of services in all counties now, January. Next slide. July, this is coming up in a couple months. ECM will begin for the following populations in so everyone else will now be able to bring those folks that the early people in January had. It's going to be available for everyone across the state for those populations in July. And that every 6 months, the managed care plans are going to add additional approved in lieu of services. Next slide. January of next year, it will be available, ECM, for all these additional individuals, people from incarceration, people in long-term care and at risk of institutionalization, nursing home residents. And again, more services. Next slide. July, ECM begins for all kids in all counties. So that's a ways off, right? But nevertheless, we start with those most in need. And then more services are going to be added. So next slide. Please be aware of the rules. I make it seem so simple, but you'll need to really study this page, because what you see in the left is the key in terms of enhanced care management as a wrap. In other words, the light blue, if you can see that, is places where you can have kind of an overlap or, but that they don't want duplication of services. Number 2, or that darker blue, is that they can be enrolled in one or the other, but not both at the same time. And then The black spaces or the dark are excluded from ECM. In other words, if you are involved in CalMedi Connect, for instance, you are not eligible for ECM. So these are the details that I will let you review. But note, hospice is one of them. So these are things to become familiar with. You will need to kind of have this understanding as these benefits come out, because what you don't want to do is not be aware that there are nuance to this ECM. Okay, next slide. Okay, so now we're going to go to community supports. Next slide. So community supports, or in lieu of services, because this is where it gets really confusing. They use similar language for all these different things. It varies, it turns out, by managed care plan and by county. And you can go to the source at the bottom to see the community support by the managed care plan and by the county. So that's a very important link for each of you to know what it is that's available. I've organized these 14 community supports by the way they were approved, but that is beyond the point. All 14 are in play. Okay, next slide. All right. The other thing I want to make you aware of in terms of this treasure trove of riches and this unprecedented investment that has come to us in the state of California is that beginning May 1st, 2022, a new law in California will give full scope Medi-Cal to adults 50 years of age or older, and immigration status does not matter. So more people are coming on. This is going to be additional pressure on the managed care plans. I'm sharing this with you because you need to appreciate all the pressures on the state general fund. Next slide. Let's talk about more funds that came to California. Home and community-based services. There was a spending plan that was also approved, and it provides California with $3 billion in enhanced federal funding to support initiatives that enhance, expand, and strengthen Medicaid's HCBS services. Now you see the details of where the money came, but these funds are in play through March 31st, 2024. It's a one-time appropriation. Okay, next slide. These are the areas of service essentially that are being funded by this $3 billion, and all the departments that are involved in the initiatives. The California Department of Aging, the California Department of Social Services, the California Department of Developmental Services. You can read the list, and more details are at the bottom below. Next slide. The other thing I wanted to share with you is that I was just at a meeting in Burbank where Joseph Billingsley had this really great slide. And he made clear, and again, there's a lot more information everywhere, but I'm trying to just get you clean, simplified information, that there's a commitment to offer coordinated care to housing and homeless incentive program. Impact will give funds to managed care programs to make investments. And so that money, those incentive payments are moving forward. Also, there's an elimination of the assisted living waiver waitlist. So there's just a lot going on in the nuance of this. And I don't know that everyone involved in each of these prongs of the system even appreciate that all this change is happening. It's just happening in so many areas. Next slide. The other thing I wanted to share with you is how it kind of, when describing all those new dollars and who's doing what, you can see that there's a new Aging and Disability Resource Connection initiative that the California Department of Aging is supporting, right? No Wrong Door. Then the workforce, the additional funding, that's by the California Department of Aging. But then you have direct care workforce and the in-home support services workforce getting an additional boost. And that's being led by the Healthcare and Access and Information Department. And then finally, the IHSS career pathways led by the Department of Social Services. So it's really confusing, all these supports. So it's, again, a whole of government approach, like all of us leaning in and supporting each other with all these new resources. Again, unprecedented, one time. You'll see all this is one time, but we're really trying to create infrastructure, as you saw, those priorities that were made clear. Okay, next slide. All right, here's some other exciting things that Medi-Cal's doing. And I know it just doesn't end. They just had a report that came out this month, and they're going to work in 8 action areas. And I share this with you because the Department of Public Health has a place, but I want you to know they're looking at starting with the community first. Remember that care model? They're living it right now. They're like talking to people, strategic planning. They're going to have just an emphasis on an advisory committee that's going to make hold them accountable and make priorities known. Number 2, they're going to think about, in this coming governor's budget, the opportunity to eliminate monthly premiums for families at 160% to 266% federal poverty level, and expand presumptive eligibility, and to expand postpartum care. I have another slide on that, but that's a huge, I mean, just think about, we just talked about people over 50 getting in to Medicaid. Just think about the increase of pressure on those funds. I share the increase of pressure because we have to go upstream. We have to incorporate CMM. How are we going to get all this done in an environment where people just have more and more needs if we're not working together? Okay, so I'm just like telling you, oh my goodness, the pressure is on. Number 3, pediatric preventive and primary care. There's going to be a push to make sure we do all the screening for children, that early and periodic screening, diagnostic, and treatment, including dental and behavioral health benefits, practice grant or practice transformation grants will have a 2-year spending authority, aim to reduce health inequity by 50% by 2025. So they're throwing sort of all sorts of opportunity in cash grants to folks that are willing to do the work. Okay, pediatric vaccinations. How are we going, you know, for instance, there's some measures they put in there, but could we do better in COVID vaccination for Medicaid population? I mean, these are things you all should be thinking about when these aims come forward. Next slide. They want to really make sure that we think about adverse childhood experiences, making sure those screenings occur, and there's a link to a resource page there. Family-centered approach. How are we making sure these families have access to CalFresh, to WIC, to home visiting for high-risk first-time moms, the coverage of community health workers and doulas? All that is under development. Number 6, how do we think about behavioral health crisis? Now, the other thing is they have some whole other new initiative on behavioral health for kids is apart from this, believe it or not. New funds, billions of dollars came in, and we're going to partner with them to think about, and this is like groundbreaking right here. The Department of Public Health is leading an effort to have a state-defined all-payer, that means commercial, Medicaid, anyone providing services at school for kids under 25 or students. And they're going to negotiate a pay scale that essentially you wouldn't have no share of cost for the beneficiary. So there's just a lot of very ambitious ideas in this area for behavioral health. And there's a huge investment. They're just millions of dollars for infrastructure for school health. Every commercial health insurance, again, has to have services in place at school or for school-aged children by 2024. Next slide. And foster care is also a priority. Next. All right. So here are the details on postpartum care. And that starts April 1st, 2022. And you can read those details there. Next slide. Also, I want to make sure that you're aware that the Department of Healthcare Services is going to take population health management very seriously. After they get these other things in play, in 2023, they're going to start on this, where they're really going to look at all the data, all these little pieces of work, and hope that they add up to something, to some real impact. So be forewarned that your work are going to help to really bend the curve in terms of those adverse impacts. We're going to have to prove that we can improve health. Next slide. All right, so the other big deal that impacts the community, and again, I'm focusing on all the things I think you should know. Did you know that the public health emergency at the federal and state level for COVID will be expiring soon? The current date is set at April 16th, 2022. That's less than 1 month away. Now, they have promised to give us 60, 90-day notice when this happens. But what you're going to find is that everyone over the past few years that's been eligible for Medicaid was not kicked off the rolls. In other words, the redetermination or renewals weren't required during the pandemic. But they will, once this emergency ends, we need to make sure that every beneficiary has their contact information updated with the county, because they're going to receive a renewal packet. And if they don't fill it out, they may be dumped off of Medicaid. The other thing is that some people will fall off because they got, maybe some funding and now they're ineligible, they got a job, and we'd want to transfer them to Covered California. There's just a lot going on. So there's more information about this, but it's a huge issue. And the federal government may extend the public health emergency because we don't know about what may rear again in terms of COVID. Next slide. Again, this is something I want to just share with you. We have work to do. Now, we've had all these opportunities, we have these fundings, we have these incentives, but we still really didn't do the job for the Medicaid population in terms of vaccinations. While they're improving across the state, and we cite in the nightly news great total state vaccination rates, the percentage of Medi-Cal beneficiaries with at least one dose lags the population at large, sometimes as much as 30%. It's terrible. So my hope is, if we can do one thing as we work together, is to really make sure we make an impact. And these are things that you all can do with the health department. We can do these things together. It's going to take time, but there's just so many opportunities for us. Okay, next slide. All right, so my vision for the future, I know I went through that. That was real whirlwind, is to partner with all of you, with others. Liz is going to go into some details of how we can come together, but how are we thinking about prevention? Those buckets of prevention, all the ways we could, draw down the new opportunities. And I didn't even go through all the other opportunities that exist in CalAIM. You saw those other areas. How are we going to connect with community-based organizations? And some of you already have those inroads. How do we track our progress? How do we ensure sustainability for this work? Okay, next slide. So I have in the next slide some things I've shared with you in the past. I commit to working on CMM moving forward because it makes a difference. I've shared with you the documentation. I've shared with you the needs we have in the state. We need to work in these frames together, I believe. But this meeting and next, the upcoming breakouts will build on this. These are just my initial thoughts. Next slide. So I'm going to leave Q&A to a later time because we're at time. And next slide, my contact information. But let's hand it over to Liz. Let's not drop or miss a beat. I know that was a lot of information, and I'm hoping and just thanking you for this opportunity. Thank you so much.
Jessica, that was incredible. I had used the analogy of lobbing softballs. You threw us about 100 fastballs of really good information. I mean, just incredible opportunities and programs coming soon, and maybe not so soon, but you really have set us up to think about what we can do to position ourselves to align with these tremendous needs. So thank you so much. It's what a perfect transition here to move from somebody who knows so much about what's happening in healthcare in California nationally to someone who is also a California national leader in policy. I don't even think that your bio does you justice, Liz. I'm going to try to do the formal part and do a little bit informal. Liz Helms is the, can I advance my slide here, sorry, is the president and CEO of the California Chronic Care Coalition. She's the author of a book called Healthcare Unhinged, amazing book. She's been a leader in patient rights since the mid-90s. Her vision, breadth of knowledge, commitment to coalition building, grassroots advocacy, strategic planning, policy development is really unmatched. It's earned her tremendous recognition and respect, again, in California and nationally. I've seen and worked with her for probably a good dozen or so years. I can tell you that my first opportunity to work with her was through the Right Care Initiative, which she was very instrumental in bringing pharmacists into as part of the care team. And I remember Liz meeting with you in San Diego that one day, and I just thought, wow, who is this powerhouse woman here who is just taking control of all this important work? And boy, that impression has never changed. I mean, every time there is policy or opportunity to bring something to the attention of legislators, lawmakers that can make all the difference in patient outcomes, Liz is there and her organization is there, either leading it or facilitating in the background key relationships to make it happen. And I'm completely explaining the complexity and the importance of the work you do, Liz. Good example, SB 493 would have never happened without Liz Helms and the team. And I won't go into the great details in that, but I know specifically some of the work that she did to make that happen. And again, we would not have provider status in California if it weren't for Liz Helms. But you can look at any legislation that is important to patients that gives pharmacists an opportunity to contribute, and you bet Liz has her thumbprints all over it. So it's a little informal, Liz, but all the awards you received, so well deserved. Always an honor to be part of any group that you're working with. So thank you so much for sharing your insights. And I think you're going to blow this group away on your tremendous knowledge on policy and how to advocate for the right things for patients. So with that, please welcome Liz Helms.
Wow, I hope I can live up to that. I really appreciate. Wow, Jessica, oh my gosh, you had so many slides, and I thought, how are you ever going to get through them? And you did, and there's so much. So I hope I build on a lot of what Jessica said, and it's great to have the partnerships with the California Right Meds Collaborative and the Department of Public Health and the Comprehensive Medication Management Work Group, and the other issues that we work on together, and I'm going to go through some of them. So thank you. I have a lot. As I was trying to put this presentation together, it's really hard because there is so much going on. It's like, what are the key points that we should be picking out? So let's go to the next slide. And so I have no conflicts of interest. So thank you. And then today we're going to be talking about the three areas of work with the California Right Meds Collaborative, and how they work with major stakeholders, and then talk about what Jessica was just talking about, all three buckets of prevention, the whole of government, a little bit about the care model, but I think she did a really good discussion about that. And then I'm going to focus a lot on how do we put this all together, and how do we build on it, and how do we actually implement it, because we see so many people working in their buckets and in their silos. And it's like, how do we get out of those silos, bring everybody together so it's really coordinated and everybody is working together. I know one of the things that I hear from people that says, the California Chronic Care Coalition is different. And it's like, well, why are we so different? It's because you want to bring people together. You're not trying to just do the work by yourself and say, oh no, this is our territory, and you shouldn't have a place in it because we've worked really hard. We're kind of the opposite of that. It's what can you do, because we can't do it all. We don't have the people power or the resources. So it's how do we build this so we can all work together. So go ahead to the next slide. So a little bit about the California Chronic Care Coalition. We actually were asked in 2006, before the ACA, by the administration, then was just Schwarzenegger administration, to get the voice of the patient to the table, because everybody else was there and talking about how we were going to work on pulling together something like the ACA before the ACA came together. And so that's kind of the impetus of how we got started. And then we launched the next year in 2007 at the state capitol with the administration and with the Department of Healthcare attending that launch to talk about how we can move forward. And so our focus is, we have over 30 leading consumer health organizations and provider groups. We don't look to have hundreds of them because we have a lot of work to do. So we do partnerships and work outside and bring in stakeholders. But just within the chronic disease community, we have these 30 groups represent over 16 million people in the state with chronic conditions. So it's pretty vast. And then we promote the collaborative work of policymakers, industry leaders, providers, and consumers to improve the health of Californians with chronic conditions. We envision a system that's accessible, affordable, of high quality, and that emphasizes prevention, coordinated care, and patients' wellness. And I think you heard a lot about that before, so we can move on to the next slide. But that is a lot of undertaking to try to make any of that happen. It's a lot of undertaking. So what we have, some of the partners that we work with in the comprehensive medication management world, for sure, with Stephen, the great group he's put together with the California Right Meds Collaborative, again with Jessica and the CMM statewide implementation work group. The Right Care Initiative was kind of where I started just before that, and I had learned about the Asheville project. And I was so interested in what they were doing in Asheville with pharmacists that I dragged my husband to Asheville, North Carolina, and sat down with them. So what are you doing here? What is so different? Why is this happening? And then brought that back to the Right Care Initiative just as it was starting. And everybody looked at me like, what do you mean pharmacists, on the care team? And what do you mean, we're physicians and we're academics and we're this and we're that. And, they just hadn't thought about the role of pharmacy. And so when we went to San Diego, we actually worked with USC School of Pharmacy, which hosted our meetings there. And we really got into that discussion. And then SCAGs did some amazing, phenomenal work with UCSD and putting the pharmacists vetting them into the office there. And then hence all of this started. And then we heard during CMMI that there was this amazing pharmacist at USC named Steve Chen. And we said, oh, we've got to meet him. We've got to meet him. And so we brought him to San Diego. And I do remember that day, Steve, because I know it wasn't easy on you. And I told you to beware, sometimes the mood in there is like, why are pharmacists here and what are we doing? And oh my gosh, what a start. I mean, we've been hitting the ground running ever since that time. Of course, we're totally working with the California Pharmacists Association. They actually sit on our board. I just came off the board of directors for the Alliance of Integrated Medication Management at the federal level. We're an executive signing organization for Get the Medicines Right, and then sit on the National Hypertension Control Roundtable Work Group. The Chronic Care Policy Alliance, we spun that off as our sister organization from the Chronic Care Coalition, and that's our national organization now. So we're actually working on federal issues and can lobby the federal government now through that organization. That's a 501c4. So a lot more to hear. But as you look at this chart right here, what's missing is we are one of the only consumer organizations that are involved in this discussion. And we've got to do better. We've got to bring on more. And I'm going to go through that a little bit. So go ahead, next slide. So in our priorities, these are the Chronic Care Coalition priorities. And if you look at right at the top, we're looking at comprehensive medication management, breaking down silos, eliminating barriers, team approaches, utilization management, vaccine education, huge. We just launched last year your vaccination guide, and I'll talk a little bit more about that later. Health equity, mental health parity, telehealth. This chart wasn't just made. This chart was made several years ago, and we're just really now having deep dive discussions about all these things. So it takes time. Sometimes the wheels move slow, and then all of a sudden they pick up speed and they move really fast, and you want to get on that bus so you can go down the road with us and be ready for it. Go ahead, next slide. So when we talk about prevention, of chronic conditions, we look at primary, secondary, and tertiary. And what does that really mean? So everybody has a different perspective of that. But primary services which prevent a condition from ever presenting, like checking your blood pressure or knowing what your numbers are, so you can prevent things from happening. And secondary services which detect a condition prior to clinical symptoms. So you start to see your A1C levels going up, or you start to find that you are more depressed than you have been, or things that you might be looking at diabetes in your family, and you say you want to turn that around and you don't want that to happen. And even in cancer care. And then the last one, tertiary services, focusing on diagnosis. So now you have a diagnosis, and then the management of chronic conditions present after clinical symptoms. So we work on all three levels. The hardest to implement is primary prevention. And I know we've come a long way, and that a lot of that is thanks to Jessica and the amazing work she's been doing at Public Health. When we go to the health plans and we say, you should be looking at, the services, they talk about never events or things that haven't happened. Why should they fund never events? It's like, well, if you put that money into avoiding tertiary services, you're going to save a lot of money. So I'll get a little bit more involved in that in just a second, but go ahead. So then we're talking about CMM in all sectors of healthcare, and that's the building blocks to whole person coordinated care. I think one of the things that the point that we really made with the Right Care Initiative is you have the teams, they're all talking about, and this was back in 2008, they're all talking about how do we build teams and coordinate care. And I kept saying, you can't do it unless the pharmacist is at that table. If they're not at the table, how are you going to do it? Because they play a very big role. They're not just there to put pills in a bottle. Their education allows them the opportunity to have deeper discussions, and even more discussions than just a consult. And I think that this is really key. So how do we build this? So we're working at the federal, the state, with the health plans, in the community, with community clinics, on building that capacity and then moving it into public policy where that work can be actually implemented and be sustainable. And I think sustainable is one of the key words here. Okay, go ahead. So let's just look for a minute at the state of chronic disease and what the drivers are in California. And we are updating this, but we talked about the leading cause of death and disability. 6 in 10 people in the state have at least one chronic condition, and 4 in 10 have 2 or more, and I think it's likely more than 2. 3.15 million in annual healthcare costs. So those keep going up, those rise. We could turn that around, and I think you saw that $500 billion number earlier that Steve showed in the beginning. There are a lot of return on investments that we are missing, but at the same time as we build quality into the system and access. And so if you look at the leading chronic diseases in California are cholesterol, hypertension, arthritis, mental illness, and diabetes. Cardiovascular disease has dropped, and I think it's dropped some because of the work that everybody's been doing on hypertension control and understanding what your numbers are. And that a lot of that has also been done with the American Heart Association in partnership with so many different organizations. Go ahead. So prevention and affordability. So if we look at 5%, like 1.6 million Californians have reported an unmet need for mental health treatment. And we just sat down and did an interview with the California Access Coalition, who is instrumental with the California behavioral health community. And we talked about this when I started in advocacy back in the 90s. We were talking about mental health then, and we were talking about the homeless population. We were talking about community coordinated services, and we had small grants that were given to start building that. And we saw really good returns on investment, and then those funds went away and those programs went away. And it's so whatever we do, and I think Jessica talked to this so much, sustainability of really good infrastructure programs are key to link these. Once we make those linkages, we don't want to lose them, because you also are building trust in the system. And if you lose the trust, you say, okay, I'm here for a moment and then I go away because I don't have the funds to continue the program. What happens? So that's how we kind of go up and down this road of, you know, the sustainability, the infrastructure, the treatment programs, what's happening in rural America versus urban America, what's happening in Medicare, rural health. There's so many facets of the care, but that doesn't mean we have the technology pieces together now that can be implemented. And I'm going to talk a lot more about that, but I want you to, this is also up on our website. On the Chronic Care Policy Alliance, we have infographics of every single state in all 50 states. We have the state of chronic disease for that particular state. So I would invite you to go to that website and take a look at what we've already been putting together. And along with that, we're in the process of uploading the federal work and work in other states that could connect to what we're also doing here in California. Go ahead. So this is where I really want to spend a lot of time because I remember one of the presentations that you made, Steve, where you had like 100 different pill bottles sitting on someone's table, and it was one person. It was just one person. And it's like, what do we do with that? When I found this slide, I said, oh my gosh, you know, this is not that far away from being truthful. And so I wanted to bring it in because, oh my gosh, what are we doing to ourselves? And so let's make the case for CMM value. We've got to make that case. We have to build that drumbeat so everybody hears it and it never stops beating. So let's talk about, I'm going to go through the care coordination, technology, stakeholder engagement, and ending with public policy. Okay. So as we talked, you know, everybody knows the problem is their suboptimal use of medication leads to poor patient outcomes and unnecessary healthcare spending. 50% of all prescriptions taken incorrectly. Drug adverse events, fourth leading cause of death in the US. I spent a couple of trips to the ER where I was admitted because they thought I was having a stroke. And what it was is there had been a reaction between two of my meds, and nobody caught it until the pharmacist did. And one time, pharmacist has said to me one day, "Are you having any significant problems?" And all of a sudden the light bulb went on. I said, "Oh my God, I am." And that's when we took a deep dive into the medicines we were taking. I went back to my doctor, and he says, "Well, I looked at that, but I wasn't sure, and so I didn't think it would really make a big deal. But in my case, I have TMJ, and I take a beta blocker that has a neurological aspect in it." And so it kept the deep brain migraines in check. And when that adverse reaction happened, it took away the ability for that medication and so it unleashed, and I lost my vision. I lost my vision in my left eye, and it was pretty scary. So the pharmacist came to my aid. I was already touting pharmacists, their role. but this really bumped it up to say this is happening to so many people and they don't even know. So how do we change that? So the solution, comprehensive medication management, provides the right drug taken at the right dose by the patient and the patient affordable price, improving patient safety and outcomes for all chronic conditions. This is so key and so important to all the work that we're doing together. And this is a call to action protecting US citizens from inappropriate medication use. And then the white paper that was done. So there are links, and those links are in this PowerPoint that I'm happy to share with you. I'm going to go into talking about what we've been doing at Covered California. So we can move on to the next slide. So comprehensive medication management. So we've been, the Chronic Care Coalition has been actively engaged or somewhat engaged since the Covered California came into existence. And they have their plan management work groups, and then they have their sub work groups and their refresh work groups. And it's complex, but it's once you're into it, you kind of get into the flow of what it is they're trying to accomplish. But I think one of the major successes for California in having an exchange is the input from stakeholders. They have never stopped having stakeholders at the table talking about the issues. And that means the plans, the consumer groups, the pharmacists, the unions, everybody has a place at this table to have at least a discussion or allowed to be to have comments added. And so this last year, the end of 2021, they had the Refresh 7 work group, and we got into sitting at the table on that one because that work group actually worked on what you're looking at at the bottom of the screen. And they really started to sound like they were lining up with the work we were doing in comprehensive med management. And we didn't want to lose that opportunity. And so we jointly, meaning California Right Meds Collaborative, the California Pharmacists Association, the California Health Collaborative, and the California Chronic Care Coalition came together and drafted joint comments. And Steve worked incredibly hard on helping us get all that terminology in there correctly. And then we submitted. And it was a lot of work because I think what we submitted was like 20 pages long. And these were the headers, but then there were the subheaders. And we filled in all the blanks, so it talked about equity and disparities, and then how to measure that. And then comprehensive diabetes care, ambulatory emergency room visits, breast cancer screenings, proportion of days covered in therapeutic categories, and then went into behavioral health. And that talked about the provider network. I mean, we have such shortages that we need more providers to be coming into healthcare, promoting access to behavioral health services, telehealth. You see how this is all connecting, and it's exactly what we're talking about here is the connectivity and the linkages, and then screenings for depression. And then it went into opioid use and how we work on that together. And then health promotion and prevention, the diabetes prevention program, supporting at-risk enrollees. And then we went to number 4 was the delivery system and payment strategies. We really wanted to focus on that because that's one of the key missing linkages that we need to really implement this and make it happen. And I can tell you, we are definitely getting closer. So then we go into networks based on value, and that was all under the delivery system. And we really focused in on that. So I'm happy to share a copy of this. I didn't add that to this, but I am happy to share a copy if you want to see what our comments actually were, because it's always great to get more input and say, hey, you missed this or you missed that, or really great, and really add some value, because comments are ongoing all the time. And the more people we can get involved with this, the better we can. And then I want to talk about the last piece, the interoperability and patient access. So we could go to the next slide. Oh, so I'll come to that later. So as we're going through this, I wanted to also, when we looked at the California blueprint that from the budget highlights that were launched this year, I wanted to show you some of these highlights, and I know Jessica touched on many of them, but I want you to look at some of these: increased transparency and accountability for insurance companies, the CalRx single purchaser for prescription drugs. We talked about the expanding coverage for undocumented. Office of Healthcare Affordability, we are actually drafting comments for that right now. When we talked about insulin and expanding access to reproductive services, a lot of money going into the opioid crisis, which is huge. And then universal health care. And we can go to the next slide. Continuing on, so with a deeper dive into behavioral health, here's what we're actually looking at. So for children's behavioral health, there was $4 billion. They added $1.5 billion in new funding. For the new Medi-Cal benefit, they added another $1.4 billion to community-based mobile crisis intervention services, and $571 million for state hospitals to stabilize and diversify for this severely mentally ill patients. And then we heard a lot about CalAIM, the whole person care, better coordination of long-term care. It should also have in it better coordination of medication management. So we still have work to do. And then we talked about premium reductions, so we can move on to the next one. This is my last couple slides, I think, are going to be really important. And then this is the governor's. I'm sorry, was that a question?
No,
okay. This was actually a quote from the California Health and Human Services Agency Secretary, Dr. Mark Daly. And I say it would be good for you. Here's where you can pull up the blueprint for 2022-23, along with the other information that Jessica gave you. We've given you a ton of reading to do. Okay, now we can go to another really important piece of what we're working on. So Medi-Cal RX. So Medi-Cal RX got started on a little bumpy road. And that's where the state has gone back to fee-for-service and implemented PBM Magellan to run the program. And I don't know, I think what happened right off the start is they had 200 people that they had hired. 100 of them were out on COVID the first week that this rolled out. Talk about impact with COVID. And so that wasn't that created kind of havoc. Since then, they've really tried to work hard. So we haven't been hard on them. We're actually trying to work with them and say, hey, we could be a resource with you. The other thing that they did here that we are super excited about is they included the real-time benefit tool. So that information flow can go between pharmacists and physicians. So physicians can see what pharmacists see in real time before that patient leaves the office. And that's what I'm going to be really focusing in on my next slide, because I know we're going to run out of time. And then, of course, we talked about CalAIM. So we can move on. Okay, this is where I really want to spend a little bit of time, because this is critical for the work you're doing in pharmacy and the work we're doing in public policy and the bill that we're running through the state capitol right now. So building on the CMS interoperability and patient access final rule, this rule would place new requirements on Medicaid and CHIP managed care plans, state Medicaid and fee-for-service programs, qualified health plans, federally facilitated exchanges to improve the electronic exchange of healthcare data and streamline the processes related to prior authorization. So we looked at what was taking place at the federal level, and we realized it didn't quite go far enough. What Medicare RX has done is they actually built in what we're trying to accomplish in the bill that we have now, which is AB 2352. And we call it the Patient RX Information and Choice Expansion, or the PRICE Act. And it is the Chronic Care Coalition sponsored bill. It'll be heard this next week in Assembly. If anybody has time to call in and do a Me Too, we'd appreciate it. So if you look at that picture on the right that I've got the arrow pointing to, there's that lock. So we know the information technology exists. We've spoken to community pharmacists. We've spoken to many of the prescribers and physician organizations who have all joined us on this quest to unlock that. The key is there, and the key is held by the health plans. The health plans need to unlock that key so the API information can flow back and forth between the pharmacy and the physician's office. So can you imagine if the physicians have the information at the time of care? Now they know what utilization management is going to be. They know if there's a prior authorization. They know if the drug is on the formulary, and they know what the cost to the patient is going to be. That conversation takes place now in the doctor's office. So now people that are coming to the pharmacy know what they're going to get, know what it's going to cost them, going to be able to get their medication and not have to spend time at the pharmacy counter and the pharmacist. I mean, it's embarrassing for everyone to have those discussions, or for the patient to leave the pharmacy counter and say, I'm sorry, I can't afford this, or I didn't know there was a prior authorization, or what am I going to do, or what. That has bottlenecked the administrative ability for pharmacists to really do the work that they need to do. So we think, okay, unlock that, and then let's go to bringing that technology in. Now that technology, this is not new technology, it exists. It's not a big deal. They just have to, they just need to unlock it so the physicians have it. And when we had our briefing 2 weeks ago, there were such compelling speeches and presentations from physicians and pharmacists that brought tears to your eyes. And we are going to share that briefing. We just finished getting it ready to go out. And so we'll be happy to share that with Steve, and he can share it with everyone, because I think it's so impactful. Because the role of pharmacists were not to just hire and hire and hire administrative people to do administrative work. The role of pharmacy is not just to dispense drugs, but to also have those key conversations with patients that they can have to look at everyone. So what you're taking, is it the right, is the dose, what, you know, and have that now conversation with the doctor in a different way than how do we get this approved? How do we get the utilization management burdens off? How do we know, you know, it's way too long. It's way too long for this to change. And we're really trying, and the health plans are opposing it. And they're opposing it for not a lot of reasons, but they said if they need to provide this information, they want it to be mandated on every physician. And we're saying we're not going to put that mandate on physicians. They want it, they're going to use it. Some physician organizations don't have electronic health records, or they do it, especially in the rural areas. So we want to make it accessible for everyone. But anyway, so this is really key and really important of us moving forward. And then I know, let me go to the next slide. So we're talking about how do we make our voices heard? So I have two slides that go into that. So this one, so Steve, Dr. Hockman and myself, we all were quoted in a press release from Get the Medicines Right, just on the 16th, this last week. And I want to really focus in on something that I said here, because we're saying that the patient needs to be part of the care team. We can't get to where we need to go unless that patient is part of the care team. So the patient should be recognized as a full member of the integrated team and be part of developing their own medication plan. As far as I'm concerned, this is me, the worst case scenario is developing a care plan without active participation and then presenting it to the patient as a fait accompli. We're living in the worst case scenario. That's exactly what's happening now in many settings. And this year we can and should be integrating patients into their own medication plan. And then what Steve said fits right into everything that we're talking about here today. So that's at the federal level. That's really starting to beat that drum, and they're working on legislation at the federal level. Now, something else just happened this week that I'm super excited about. So let's go to the next slide. Okay, so here's where it all comes together, and here's where you can all be a part. So whether we're doing state legislation, legislation, everybody's voice needs to be heard. And if you're not associated, you're just a patient, or you're a student, or you are part of an organization, you can send in a letter of support. Excuse me. There's no reason why you can't. And so what happened this last week, and I just found out about this as this had all started to come together, as Jessica was talking about the ending of the emergency on COVID, this actually begins to extend that. This is what this bill is all about. So this week, just a few days ago, a team of congressional delegates came together and introduced HR 7213, the Equitable Community Access to Pharmacist Services Act, that would ensure patients continue to have access to essential pandemic and pandemic-related health services provided by pharmacists. This is huge. And let me tell you what else has happened from this. So if you look at the next line, more than 100 national and state-based organizations representing patients, pharmacists, community pharmacies, and rural and underserved communities applaud this legislation. So what we do, and why is this important? This is how we build the coalition. This is how we utilize social media to where we need it. This is how our voice gets heard in a different way. And then what we're doing through the Chronic Care Policy Alliance is we are doing direct Facebook ads to influencers at the federal level on issues that can educate them, with them going to our LinkedIn page and to our blog posts that we're putting on the Chronic Care Policy website. What does that mean? That means that people that are interested in what we're doing are some of our target. And so we want to educate them on these issues. And so how are we doing, how can we do that any better? I have to tell you, we've had over 1 million hits to that website. We've had over 6,000 people sign up, because they can sign up and then we can capture the information of who they are, that they want to be on our email list, so they can now get more information from us, our newsletters and things like that. This is how you build a coalition. This is how you build it to make things happen, make them work. At the state level, it's no different, building coalitions like we're doing now around comprehensive medication management, or what we're doing at the federal level to build on the pharmacists. And so I said to the people that organized this, I said, oh, okay, so you've got the Future of Pharmacy Care Coalition. Can we just kind of roll this over when we're done with this into a comprehensive medication management coalition that can really take this on? Because you're going to have we're all going to be there together already. Let's not recreate the wheel. Let's just add another spoke to it so we can go right into that. And I was going to say, to click on that Future of Pharmacy, but I think we don't have enough time. And oh, you did it. Okay, so this is where you go to the resource section and click on that, and then just kind of scroll down. So now you start to see how this coalition is coming together, the letter writing, the handouts, the infomercials, the blogs, the letters. This is what it takes to build a coalition. It takes resources to do it. but this is this is the road to success. And so there's so much for us to do ahead. And we're so excited to be a part of this, and we're on the launch of this. So, thank you for that. And I think you could just, there, you did better than me. So this is what I am bringing to you today. I want to show you the vaccine guide that we have. We also launched it in Spanish, and keeping up on it is another big project, but we want to be sure that people keep up with their regular, not just the COVID, but with their regular vaccines. So there's a lot of information. There's personal stories. We have 2 medical advisors, Dr. Balmer and Dr. Revelo, that are doing it in English and in Spanish. And we're so excited about that. So Steve and the California Right Meds Collaborative, thank you so much for having me here today. And I will turn it back over to you.
Wow, Liz, boy, you think that Jessica had a lot to share, and yet I think you've got just as much on the policy side. I don't know if this does you justice, but you're a master at taking things that are happening at the highest priority across the nation and translating it into actionable and very powerful steps to get us towards resolving those issues. And I've seen you do this over and over again. Recognize a need, connect it to the right group, organization, party. Covered California, what a great example. It's because of you that we were able to get to the table and get as far as we have with them. So thank you for all that you do. I was, as you know, extremely excited to have you speak because I've seen you do this so long, and people need to know, understand what you're doing, the value of what you're doing, and to your point, take action, right? You're directing us to some prime opportunities to advance the profession. And so I hope that this group and others that watch the presentation will follow your lead and your charge. So thank you again for sharing this great information.
Well, thank you
this
so
is
much.
Perfect. Thank you. This is perfect because it leads us into a breakout. I know we have about 20 minutes left, so we'll try to be as efficient as we can, because we probably have, we'll make 20 minutes work. We're going to break out for, Lisa, how about, what do you think? 6 minutes, 7 minutes, 6 minutes? Okay, let's do 6 minutes of breakout. And boy, these questions don't really do the 2 presentations justice, but we really wanted you to take a moment. You've heard about 90 minutes now, maybe somewhere in that range, maybe 80 minutes of just a lot of very relevant information to your practice as a pharmacist, whether you're a frontline pharmacist or a senior leader pharmacist. And we wanted to hear some takeaways. What did you hear that excited, surprised, shocked you today? And then what can you do by next Tuesday to start advancing the availability of CMM services, given what you heard? I know these sound like very simple questions, but we're trying to get you to articulate what are some things that you can do now to support and to advance what you just heard. So with that, we're going to break you into small groups and name one of you as the sort of note taker, because when you come back, we're going to have you share your comments. So go ahead and join. I think the groups are up. We'll see you back in 6 minutes. funny how 6 minutes goes very quickly.
It's just, but I am excited. If I'm retired, I haven't taken part in a lot of different things, but I
I think, Neil, you cut yourself off in the middle of what you said.
We were having a good conversation with Neil.
Oh, okay, good. Any conversation with Neil is a good conversation. I guarantee you that. All right, let's see. Are we all back yet? I think we are. Great. Okay. So thank you. I know, again, 6 minutes goes very fast, and I appreciate you all taking that moment. I think if we had not done this and we just asked people to respond, you'd still be trying to recover from drinking that water from a fire hose. Hopefully this gives some time to think about what was shared. And at this point, we'd like to hear some of those responses. So again, addressing either both of these questions, anything you heard that was exciting or surprising, and then anything that you can think of in terms of next steps very soon that you can take to advance the availability of CMM services in alignment with what you just heard. Who'd like to share first? Any of your comments?
I can share, Steve.
Thanks, Allison.
Hi, everyone. I'm Allison. And in my group, I had Bruno and Bernadette. So we talked about that we were excited or surprised by the upcoming change in eligibility for Medi-Cal and how that's going to increase the number of patients and services. And also, I'm really excited about hearing all the policy that's happening for future change. And then also, Bruno was sharing with us some methods that he uses to get access to labs for CMM, talking to the provider or the patient or even the lab. And then also in the case of IHP, being able to actually log into the health plan and get access to those labs or even medication lists if that's shared with the health plan. And then we're looking forward to learning more about the policy on the websites that Liz provided, and hopefully lending our support through posts on LinkedIn and letters and whatever we can.
Great. That's a great next Tuesday goal for everybody. Thank you, Allison. Fantastic. And I can just add that in my group, Janice Cooper and I were talking about very similar things. That she was super excited about the fact that comprehensive medication management, Cal Right Meds, has been able to reach the attention of so many senior leaders and people that are trying to move the needle in healthcare, as you just heard. That idea of being at the table at the beginning as opposed at the end when all the decisions are made. That's here and now, right? People are reaching out and asking for pharmacists, CMM representatives to be present as these discussions are made. And the one frustration that Janice shared, which I think many of you can resonate with, is there's a good amount of evidence. You saw some of it cited today about the value of comprehensive medication management, and yet when you approach different stakeholders, payers, health systems about CMM, oftentimes the response you get is, "Oh, we need to do a demonstration project," right? How many times do we have to re-demonstrate the same thing over and over again? What I love about what Liz did recently with Cover California is, she approached them and said, we have all this evidence on CMM. What can we do to move it forward? Do we have to do another demonstration project? And I think she asked it in a way to basically move them to say no. And basically that's the answer they got. No, let's just implement. Let's just make this happen. And that's what we want to start hearing more of. Is the evidence is already there. Let's just figure out how to make this happen. And we're seeing more of that than ever. Thanks for sharing that, Allison. Liz, do you have any comments? I don't want to. I think this is right in your domain.
Thanks, Steve. I think that I can feel excitement here. I can feel just watching what's going on in the chat box. And I was just in the room with Dr. Sabor Shahzaz, and we were talking about what he was going to say. He might want to bring that up, what he can already do. He says, "This is what I can do," and he works out of LA County in the Imperial Valley. And so engage and be involved. Those are the words that we want to hear. Be engaged and be involved. You could be engaged, but if you're not involved, you're engaged. You know, you can watch TV and yell at the TV at policies that you're hearing that are going on, and you're engaged because you're like, okay, shouting at the TV, or you're, you know, saying, oh no, this should happen, this should. But to get involved is where it really happens. That's what makes a difference.
Great, thank you, thank you. All right, anyone else? Maybe time for one more. Neil, are you talking to us? I'm sorry, I think you're on mute if you're trying to speak to us.
Okay, I would say being in and out of it as trying to do something as an independent consultant, I'm very excited about what the state is doing for their Medi-Cal recipients, that they're very much behind improving the care and doing it on a large scale basis. I think that's really critical. I'd like to see a little bit more, probably a little bit more, less demonstration projects, more education of private physicians about the program, because that's where to me, that's where my stumbling block was in Fresno. I couldn't get any traction among the independent providers I was approaching because I was an independent consultant. And that's really a difficult way to go. But I think you need more education really just to hammer them about how much better their practices could be if they were to integrate somebody on even on a one-on-one basis to provide the service for their patients. It's, you know, that's the hard way to go. Especially in my particular geographic area, that's probably why I stopped, because there was no I couldn't get any traction with the independent providers. So it's kind of hard.
Yeah, that's great. Actually, I'm glad you brought that up, Neil. And what Liz had mentioned before, the group that we both work with, the Right Care Initiative, that's very much what they do. This is largely a non-pharmacist organization founded by an MPA, Hattie Hanley. And most of the speakers are physicians, I would say. And I find that whenever I need a group that can help advocate for doing the right thing for patients, including advancing pharmacists and the care team, they're extremely great. I call on many of them to do that on our behalf. And that might be a group you can connect with. I can get you a link to that meeting if you'd like to participate and see what is involved in that.
I'm technically truly retired now. I'm technically truly retired. So I'm,
okay.
But, you know, I still have an interest because I've always wanted to see the profession advance. And I think
absolutely
they're on the cusp of a lot of, it's really critical now because with the pandemic, it created a situation where there's actually more of a need for patients to be managed properly because they're shut-ins. They're not going anywhere. They can't get access to their medications properly or within the normal systems. And they need more in-home care connection with on a basis to get their meds managed, even to get them to the house, even to get them from their pharmacy into their hands. So I think we could leverage the pandemic to a great benefit if we really come out a little bit stronger.
Yeah, and you know, at the learning session at Western Pharmacy Exchange, you're going to hear a lot more about some of the plans and their goals in terms of getting meds to patients such as homeless populations that are struggling. So thank you so much for sharing that. I know we only have 2 minutes left, so I'm going to try to kind of move this forward a little bit faster here. Now, I would like you to do this while I'm closing out the meeting. So I'm going to have you in the next, it says 5 minutes, but now 2 minutes. If you can in the chat, just type in a few of your thoughts on these two questions. What are your greatest challenges in engaging or retaining patients for longitudinal services, such as comprehensive medication management? And then what are your greatest challenges you've encountered in working with patients with mental health disorders? And I'm asking you these things because we already have speakers addressing these topics, but we also, as much as possible, want to tailor the content to any specific needs that you have. So again, as I speak and close out this meeting, please think about these two questions. Again, engagement and retention of patients in longitudinal programs and working with patients with mental health disorders. What are some of your greatest challenges? Pop those in the chat for us. We'll record those and we'll incorporate those into the learning session coming up. Right, so what's next? I'm going to give you a quick highlight as to what you're going to hear on April 22nd at the Cal Right Med's learning session for spring. This is right along with the thing that we've heard today. We need to be ready. We need to be ready for all these opportunities that are here now. They're coming very quickly, right? And in order to do that, we want to accelerate the work of this collaborative, more health plans, more patients, more high risk. So for our upcoming learning session on April 22nd, we'll update you on what's happened since the last learning session. For those of you that haven't been part of the collaborative, two of our health plans, IHP and LA Care, will give us updates on where they're at in terms of growing the collaborative. I think you'll be real excited because not all of this is usually shared in our regular meetings within our teams. A couple of our teams will share their best practice approach to delivering comprehensive medication management. We'll hear about new health plans, new opportunities for CalRightMed's pharmacists. A big push is the reason for the previous questions. We're hearing a lot of challenges with working with patients with both mental and physical related challenges. And so we're going to start to infuse more training on psychiatric medication management into comprehensive medication management. There'll be a plenary session as well as a breakout on soft skills for mental health patients. You're also kind of related to that. We'll have another expert, David Dadiomoff, speaking about managing patients with substance abuse disorders. And then a couple for newer teams, patient engagement and retention, thus the previous question, and then hypertension management pearls. If there's a disease state that we want to be able to really knock out within this collaborative, it's hypertension. There's so much national and local attention to our miserable rates of controlling hypertension. We can do better. And we know that pharmacists are key to making a difference in managing hypertension. So that's basically just a rough overview as to where we're going to be covering in that learning session. If you scan this barcode and go to that link, you can get the registration information. And with that, I think that brings us to the end. So if you haven't, oh great, I see some chats coming in. Thank you so much for that. Again, a reminder that if you can, and I'm sorry, I don't think this is the right date, I think. No, it's not. If you can complete this survey from Department of Public Health, LA County Department of Public Health on CMM by the learning session, April 22nd, we would greatly appreciate that. I think the link is in the chat as well, but this barcode will also get you to that survey. With that, I want to thank everybody, our speakers first and foremost, for not just the content, but taking the time to put all that together. I mean, the work that you do, both Liz and Dr. Jessica Nunez-Guevara do, it's evolving constantly. The updates you gave us were from yesterday, basically. And just your willingness to share and get this group inspired and activated to do things that will advance care for patients and for the profession is greatly appreciated. So I want to thank you both. Thank you all for participating, for teams that are part of CalRightMeds. You know this work, you're in it. You know it's not easy, but I hear from you all the time that it's rewarding. You appreciate that there's support for doing what's right for patients. And for those of you that are not part of CalRightMeds, I hope you'll consider joining. I think what you're hearing today very clearly is we need to be ready as a profession. We can't wait until everything is in place and say, hey, we want a seat at the table. Now we want to join. We need to be ready to offer high-level comprehensive medication management to our most challenging patients, because you can see the writing's on the wall. There are investments being made in this direction. It's going to happen. So even if you aren't part of our CalRightMeds collaborative team at the moment, please consider joining our meetings, joining our collaborative, taking part in the training. Not only this learning session coming up, but in May, we have a couple of live in-person learning sessions that are going to involve patient actors to refine your skills at delivering comprehensive medication management. We have webinars. We have a lot of support to advance your ability to deliver this care. So please consider it if you aren't part of the collaborative. Lisa, any last instructions for participants?
So I'm going to be sending an email next week with instructions on how to claim your CME or your CE, sorry. And then I'm also going to be uploading the presentations to our LMS, which is Lecture Panda. And I'll also upload the recording of this session.
Great. Thank you so much for keeping us on this whole complicated program together. You made all the difference. So with that, I hope I will see all of you virtually or in person at the learning session on April 22nd. So thank you all. Have a great rest of your Sunday and have a great week coming up.